Welcome to Broad Eye, the podcast that explores knowledge gaps in ophthalmology and eye care.
Welcome to the Broad Eye podcast. My name is Dr. Debra-Meghan Sanft, known as Megan to my friends, and I'd like to introduce you to Dr. Reimer, who I'm going to call Katie. And we went to medical school together, and she's a family doctor, and I'm an ophthalmologist. And we're bringing you an episode today where we could talk about how the eyes also tell us things about what's going on in the body and how the things that we need to look at in the eye. So why don't we kick things off with a very common disease that is common both for family doctors and for ophthalmologists. And let's start with thyroid disease.
So Megan, so this is Katie speaking. And so Megan, what would make you be worried that someone might have a thyroid-related eye disease?
So thyroid eye disease is most frequently associated with people who have hyperthyroidism, which is about in 90% of the cases. And then the rest of the 10% of the cases either have a normal thyroid function or an underfunctioning, also known as hypothyroidism. And some of the things that I would look for on physical exam are things like eyelid retraction, which is the most common presenting sign of thyroid eye disease, lid lags of the upper eyelids on downward gaze, unilateral or bilateral axial proptosis. So one eye or both eyes appear very prominent when looking at the patient. And this has secondary things, like you could get exposure of the cornea causing very dry eyes, as well as the extraocular muscles, the muscles that move the eye, can frequently become thickened and enlarged. And this can cause trouble looking up or double vision. And the last thing, which is very rare in about less than 5% of patients, is something called compressive optic neuropathy. And this is an ophthalmological emergency due to the extraocular muscles and the orbital fat just getting bigger and causing compression of the optic nerve. But it's very rare, so I don't want people to worry about this. So Katie, tell me, when you get patients from a referring doctor wondering about thyroid-related diseases, what are some of the things that you ask the patient?
So that's a great question, Megan. So family doctors get asked many questions about possible thyroid-related illness, maybe because it's actually a topic that's very often discussed and family members are very open about having thyroid disease. I guess there's no real stigma related to that. And what would be most important to identify would be whether the patient could be in a low, so hypothyroid state, or a high hyperthyroid state. So symptoms of a hypothyroid state would include fatigue, weight gain, increased in period or menstrual flow in women, constipation, always feeling colder than others in the same sort of environment, dry skin, and sometimes even mental health changes, most notably depression. And how do we remember this? Is these are symptoms of a slow metabolic state. And so hypo, slow, those go together. Symptoms of a hyperthyroid state include unintentional weight loss. So people who say, oh my God, I've lost 15 pounds in the last month for no reason. Light periods, diarrhea, sweating, or consequently feeling hotter than others, palpitations, and some mental health changes as well, notably anxiety. And it's also important whether there are any thyroid diseases in the person's family. So again, not only hypo or hyper, but history of thyroid masses, thyroid cancer, goiter, some of those examples.
So let's say a patient comes to you and they're having symptoms of either hypo or hyperthyroidism. What kind of investigations or blood tests would you do at that point?
So identifying whether someone has a thyroid condition or not is actually quite straightforward. Testing a person's TSH or thyroid stimulating hormone would be the first step. The doctor might only order a TSH on the blood test, but thankfully the lab where the blood test is being drawn will automatically add your T3 and T4 levels if the TSH itself is outside of the normal range. T3, T4 are the active thyroid hormones that the body actually uses. And so a low T3 or T4 equals hypothyroid, and a high T3 or T4 means hyperthyroid. We do have the option to also check thyroid antibodies as well. once a thyroid condition is diagnosed. This is also a blood test, and a thyroid ultrasound can also be done to document if there are any thyroid nodules, if there's a goiter or a global increase in size of the thyroid gland, or other masses that might also be present and of concern.
So I think that this is a lot of information for people. And before we totally scare them, we should let them know that thyroid-related disease is something that's completely treatable. And maybe if you just want to let us know what some of the treatments are that are available.
Of course. So yeah, so thyroid illnesses are very, very much treatable. And the principle of treatment of hypothyroidism hinges on the replacement of thyroid hormone with a synthetic thyroid hormone, also known as Synthroid. So you kind of see how those words go together. And the dose of Synthroid is really person dependent. Some people need varying doses of thyroid hormone, and it's not always like, oh, she's a small woman, so she needs a small dose, and he's a big man, so he needs a big dose. I have some small women who take higher doses than, you know, some probably weightlifters could. And the treatment of hypothyroidism really hinges on getting the TSH to return to a normal range, as well as the T3 and T4. And then treatment of hyperthyroidism is a little more complex, as there can be many reasons someone is hyperthyroid. So if a patient has an overactive nodule in their thyroid, it can be treated with radioactive iodine. So that's when the patient actually ingests a radioactive substance, iodine, that is then picked up by the thyroid gland, and from there kind of sort of renders those cells that pick up that iodine inactive. So that's one treatment. Part of the thyroid can be removed surgically, and other oral medications can be given as well, depending on the severity of the hyperthyroidism and depending on the cause as well.
Do you think you get superpowers when you ingest the radioactive iodine?
That would, you know, sort of Spider-Man sort of things. The one thing I do know is that anyone who is taking the radioactive iodine, no one else can handle, or they have to make sure that after they use the washroom and other family members are in the home, that they have to clean down the washroom very well, because they can actually excrete some radioactive particles. So we really gotta be careful there. And so, question for you, Megan. So once the patient is diagnosed with a thyroid condition or eye disease itself, how often do they need to come to see you for follow-up?
So if someone is diagnosed with a thyroid condition, they don't necessarily have to come see the ophthalmologist, but a lot of people have mild symptoms of one thing or the other. So they do often end up in my chair. If there's some thyroid-related eye disease, either the eyes are more prominent or it's causing severe dry eye, as long as things are stable, I usually let them know that I could see them every 6 months or once a year is usually enough. But then, of course, if there's things that are really difficult to get under control, like very bad dry eyes because of exposure, or I'm worried about any compression of the nerve, these are things that get followed up extremely carefully and closely. But it really depends on what the person's bothered by. It's not something that necessarily has this number of months for every person with thyroid disease. It's something that's very tailored to the person and their experience.
And are any of the treatment options that would make you want to have the patient come in and see you more often?
Yeah, so actually with hyperthyroidism, as we were talking about the radioactive iodine, right after or soon after, in the weeks or months following the ingestion of the iodine, the thyroid eye disease can actually get a little bit or significantly worse. So in these cases, I like to see them soon after that they have it, and a few weeks or months later, depending on how they're feeling and how their blood tests are leveling out.
Oh, that's good to know. And on my part, that's good to know as well.
Yeah, that's what this podcast is all about. So, Katie, I was thinking that we could also talk about diabetes, since it's something we both deal with all the time and is quite common in the general population.
Yeah, I think that's a great idea. And so to start off, Megan, so do you often see patients getting screened for diabetes?
Yeah, so the interesting thing about diabetes is there's a shocking number of times per year that I examine someone who comes in just for a routine yearly checkup, and I find changes related to diabetes. So sometimes I find it and have to send patients to the family doctor to get worked up. But when people are initially diagnosed with diabetes, type 2 diabetes, they often get sent to me right away just because it's not always known how long the person has had diabetes for. But patients with type 1 diabetes, usually they're even getting checked as a kid. So it depends on everyone's situation, but I often see patients in relation to their diabetes. And it, like I said, it's up to me to make sure sometimes that patients are evaluated and started on the appropriate treatment. But that's when I need friends like you, Katie, who take care of the whole body. So when you get a referral from an ophthalmologist or another eye care specialist telling you that they suspect that one of your patients in your practice has diabetes, what are some of the things that you do to look into it or investigate it?
Yeah, so as you already said, Megan, diabetes is one of the most common medical conditions in family practice, and especially these days, unfortunately, with worsening habits of eating healthy and exercising. We currently use certain screening tests to detect diabetes early, and so we recommend starting screening at around age 40 or earlier, depending on certain risk factors. For example, family history of diabetes, personal obesity, so anyone with a BMI over 30, history of smoking, and of course various other symptoms. Blood test screening includes the hemoglobin A1C, as well as the fasting sugar or glucose. The hemoglobin A1C basically measures the percentage of your hemoglobin or your red blood cells that have sugar attached to them. So we all need to have sugar in our blood. And so it's normal to have a certain percentage of our red blood cells that have sugar on them. But diabetes is when that percentage increases above 6.5%. And these results can be classified either as normal, so that's an A1C below 6%, pre-diabetic, which is between 6 to 6.4, and diabetic itself, which is over 6.5%.
So let's say you get these hemoglobin A1C blood test results, and it's suggestive that the patients that I've sent to you or patients that you're screening regularly in your clinic have diabetes. Does it always need to be treated? And if so, what are some of the things that you do with patients in order to get the treatment started?
Yeah, so diabetes, just a note, diabetes always has to be treated. So by treated, I don't necessarily mean starting medication, but we always have to make certain changes to treat the diabetes and prevent it from getting worse, because there are certain consequences of untreated diabetes that are very important to prevent. And so, for example, if the result of the A1C comes back as pre-diabetes, then usually lifestyle modifications, for example, diet and exercise, are implemented to try and achieve a healthy sugar level. And with luck, if the patient is motivated and they get a lot of support from their doctor, nurses, dietitians, etc., then they're able to bring themselves back down into a healthy sugar level, which is always our goal. However, if unfortunately they are just diagnosed with full-out diabetes right off the bat, or if they are not as able to follow the lifestyle recommendations, then they might go up to diabetes itself. So diabetes type 2, which is usually diagnosed in adulthood. We add what we call oral hypoglycemic agents, or OHAs, as well as doing the strict lifestyle modification. So we never, doctors will never suggest to give up lifestyle modifications. They'll always say that that's the crux of treating diabetes, and that all the other treatments are supportive from there. There are many different types of OHAs. However, if these fail after adding, maybe 3 or 4 different medications, if these fail to reduce the A1C into an acceptable level, then we do usually have to move on to insulin injections, and that can be anywhere from 1 up to 4 times per day. And so patients very often want to avoid insulin injections as much as possible, which I totally understand and I agree with. However, it requires, a joint effort in terms of getting them into a healthy A1C range, which for most diabetics is an A1C under 7%. That's usually our goal. And then Megan, once the patient is diagnosed with diabetes, how often should they see you to check on their eyes, which is, like I said, one of the consequences of diabetes that we want to avoid?
Yeah, so in general, patients should be seen at least once a year if they're known to have systemic diabetes to see if there's any ocular complications. That being said, there are different kinds of symptoms of diabetes, signs and symptoms of diabetes in the eyes, and two broad classes. So there's non-proliferative diabetic retinopathy, which then gets further classified into mild, moderate, and severe. And then there's proliferative diabetic retinopathy, which is when there's abnormal blood vessels that are growing either on the retina, around the optic nerve, or from the retina into the vitreous. And then you could get diabetic bleeds and things like that. As well, you can also get diabetic macular edema, which is a fancy way of saying that the retina, which is the wallpaper of the eye or the film in the camera of the eye, becomes swollen in its center. And all of these different things can change how frequently a person gets followed up. So for example, if a person has diabetic macular edema and it fits the criteria of needing treatment, then we also give needles to patients, and I think they might like it even less than the needles that you're giving them, because for us it's intraocular, or a very fancy way of saying needles into the eye. Very small needles, and people are frozen well, and it's actually quite painless. But it's usually pretty a good motivator for me to say, your family doctor told you, and I'm telling you again. Sugar control at this point becomes very important for them as well, because it could help, not only the local treatments with the needles or sometimes lasers, but just the systemic control can help the eyes improve as well. So if there's any findings or things that I'm worried about, I'll see them more often, but at the bare minimum, if it, a once a year checkup is definitely recommended.
Awesome. Your reference to the retina being the film of the camera of the eye, or the wallpaper of the eye, I really, I feel that. I'm going to start using that with my patients as well.
Yeah, I love the analogy of the eye like a camera. The lens is the cataract, and the retina is the film. Yeah, cool. So the diabetes affects really the back part of the eye, which is the retina. Yeah, I'm glad I could give you some fancy lingo to use. I think that might be a good time to pivot away from diabetes. And so I was thinking that we could talk about headaches, because headaches are this medical phenomenon where people are really suffering, and they go from their family doctor to their eye doctor to other healthcare specialists. So I was thinking maybe we could talk about, things that you hear from your patients, and things that I see when I see people, or look for when I see people with headaches. So maybe Katie, if you want to dive in and tell me what kind of headache complaints, for example, would make you think that your patient should go see an eye care professional.
Yeah. So besides thyroid disease and diabetes, headaches is another super frequent reason for consultation in a family medicine clinic. And often, I would say more often than not, I suggest that my patients with headaches check with maybe not necessarily an ophthalmologist, but definitely an optometrist to check the health of their eyes in general, but specifically if they have headaches that include visual changes, right? So blurry vision, loss of vision, black spots in their vision, so really areas that they really can't see anything, or if they have a red or painful eye, I definitely would refer them to get their eyes checked, and other neurological symptoms as well. So things like numbness, not necessarily in the eye or around the eye or on the face, but body numbness, any sort of focal weakness, loss of motor function in certain parts of the body as well, should trigger the thought to send them to see an eye health professional as well. And in that vein, Megan, if you have someone who's referred to you whether they have headaches or not, but in the context specifically of headaches, what are some of the things that you yourself ask on history when you're trying to figure out if these headaches potentially could be related to the eyes or certain eye conditions?
Yeah, so sometimes being an ophthalmologist feels a little bit like being a detective. So even it's funny because you would think that some of the questions that I ask, the answers would be obvious, but it isn't always. And one of the things I do is I ask patients to do headache journals. So I ask them, how often are you getting headaches per month? Is there anything obvious that's triggering it? Reading, driving, any foods that you're eating? And it's not always obvious. People know that they have headaches and they know they're suffering, and they're definitely suffering. But in order to tease things out a little bit, if patients don't have good answers to those questions, I often ask them to do a headache journal. Just keep a little post-it note or scrap paper in their pocket or their purse, and make a note of what they were doing around when they noticed that they were getting a headache. And then, things that would worry me, things like nausea and vomiting, of course, any changes in your vision, or the patient's vision rather, not yours, Katie. And, there's some systemic conditions as well. Specifically, the one I'm thinking of is called IIH, or idiopathic intracranial hypertension, also known as pseudotumor cerebri. And these patients present often with transient visual obscuration. So what that means is a darkening of the vision, often when changing position from lying or lying to sitting, or standing too quickly, or with exercise as well. That would make me think of that. And a whooshing in their ears, like a ch. And I made that sound on the podcast, and it's just as embarrassing when I make it in person. But sometimes patients, their eyes get really wide and they go, "How did you know I was hearing that?" So those are some of the things that I ask when I think about headaches. And then other things, because in ophthalmology, we see a lot of patients with migraines, because we can get ocular symptoms to migraine. So things like photophobia, which is a fancy way of saying the light really bothers them, phonophobia, which is noises bothering them, and scintillating scotomas, which are, one of the patients described it to me as little shimmering fireflies in their eyesight. And cluster headaches actually cause a lot of eye symptoms. So they get tearing, they get horrible pain behind the eye, as well as blurry vision, a bit of conjunctival injection, or like a pinkish or red eye. So those are some of the places where I start. And obviously there's not one clue, but so these patients get the full eye exam, the front and the dilated exam. And the thing I'm always wanting to see in these cases is the optic nerve. And that's because with optic nerve swelling, it can be an indication of something that's going on inside the head with the brain, or too much fluid around the brain and things like that. So I'm always, silently hoping to myself, having my toes crossed, because I'm using my hands to examine the patient. But I'm always really hoping there's no optic nerve swelling. And like you were saying, it can also be a refractive problem. So a question about glasses. So if my exam is totally normal, then I usually tell patients to see their optometrist, like you were saying, in case it's just a question of glasses needing to be tweaked. So let's say you send me a patient and I examine them, and it's completely normal in terms of their eye exam. What are some simple ways that some patients could manage headaches? Because these people really are suffering. So I'm sure you have some tricks up your sleeve for them.
Yeah, so headaches, and so what I explain to patients about headaches is that the head hurting, unlike the shoulder hurting, unlike the knee hurting, unlike the belly hurting, does not necessarily mean there is a problem in the brain. And so a lot of people get worried about, could they have a brain tumor? Could they be bleeding in their brain? And for all medical concerns and conditions, I always tell my patients, anything is possible, but let's talk about what's probable. And so someone with headaches, again, we think, oh, there must be something wrong with my head. So we check the eyes, maybe we check the hearing, and okay, like both of those are fine. But there can be many kind of innocuous things that we don't really consider could be problematic in our daily lives that can lead to us having headaches. And so there are many lifestyle or habit changes that can lead to an improvement of chronic, recurrent, or difficult to treat headaches. So making sure to eat regular meals throughout the day. So not skipping meals, not even having snacks regularly can help as well. Exercising regularly. And again, what I tell my patients, that's not necessarily, I don't mean for you to go start CrossFit, you just going outside for a walk, getting fresh air, deconnecting from your job, from, the stressors in your life can be very helpful. And finally, ensuring regular sleep hours. So if you usually go to sleep at 11 and wake up at 7, then it's good to keep those regular hours. If one night you go to bed at 2 and wake up at 10, that can be very hard on your overall lifestyle, and that could lead to having headaches, even though you still slept 8 hours. And some of these changes, if you're able to implement them regularly, they can have long-lasting effects. And another big one, especially broached in these COVID times, is managing stress. So stress reduction strategies, so whether that includes deep breathing, things like yoga, Tai Chi, meditation, mindfulness. These are all things that a lot of people scoff at, but that could really, help you learn how to deconnect from stressors, especially working from home, living at home, being at home. It's a lot to take on. And reduction in screen time, that's a hard one, right? So our charts as doctors are often on the computer. We're often consulting results on the computer. I'm writing people referrals on the computer. I'm looking up things on my phone. Reduction in screen time is very, very hard. But if you're able to make certain adjustments and ways to reduce, I would definitely encourage that if we can. Sometimes it's unavoidable, but we do our best. And then finally, the use of occasional Tylenol and Advil for those, bigger headaches is totally fine. Using them as needed, and not just like, oh, well, I think I'm going to have a headache today, so I'm going to take one in response or in prophylaxis of that. We don't like that as much because there is a medical condition called medication overuse headache. And that basically happens when people are taking Tylenol and Advil on such a regular basis that when they don't take it, they get a headache. And so that's something that, again, we just want to try to avoid, but definitely using Tylenol or other NSAIDs, as we refer to, which stand for non-steroidal anti-inflammatory drugs, can be very helpful in reducing the severity and the intensity of most headaches.
I love that you brought up reduction in screen time, because I tell this to my patients all the time. I mean, too many staring activities, which I always say is being iPhone, iPad, computer. We blink a lot less, so our eyes get drier. So there becomes a discomfort at that level too. But looking at things that are backlit all the time, there's just like someone's constantly sort of shining a dim flashlight into your eyes, and people don't really think of it that way. But it's something that I always recommend to patients, especially they come in, and pain behind the eyes for me is, more times than not headache, rather than being something serious. So I talk about reducing screen time with my patients all the time. And now it's sort of funny because I get laughed at and they're like, with COVID, what else is there to do? So it's very nice that things are opening up again. Hopefully we see a little bit less of these screen related headaches in the coming months and years. And I think those are 3 pretty good topics, 3 things that we, see together, not together, but independently together quite often. And I remember when I started my practice, you'd already been in practice for a few years because of the difference in length of residency. And I said to you, I wrote back this note to a family doctor about something, and I was worried. I was worried that it would be taken the wrong way. And I was, about diabetes, and I would suggest this and that, and, just letting you know that it's not under control. And I was worried how it would be received by the other person. And I've really come to notice, now having been in practice for a few years, that it really is so important to communicate with other health professionals, especially referring doctors, and how a little note, 1 or 2 sentences, goes a really long way. And I was wondering, what your thoughts were on that. Do you prefer letters back? Do you prefer to hear from the patient? As a family doctor referring patients to specialists, especially eye care specialists, what's your preference? What do you think?
Yeah, so I definitely agree with you there, Megan. As a family doctor, I'm kind of the coordinator of care. So the more I know about who my patient is seeing, how often they're seeing them, what they're seeing, how things are changing, means so much. There, there are, certain information that the patient can share with me, and they can say, "Oh, my endocrinologist gave me this medicine," and they can show me. But when I'm really trying to find out like specifics on how severe is your condition, how often do you have to do blood tests, when should you see them again, patients unfortunately can sometimes not remember all that information or not retain that information. And so when I can say, "Oh, well, yeah, I got the note back from Dr. Sanft, who saw you for your diabetic retinopathy, and she says that she'd want to see you again in 6 months," they go, "Oh, right. I didn't remember she said 6 months." So I can help additionally be a coordinator of care, and ensure that everything is staying up to date for my patients. Just like you said, with a little note back, doesn't have to be so extensive and detailed. It just has to say, "Hi there, I saw your patient, you were right, they have this and I want to do this," or actually, they actually have a different condition, and I want to treat them this way instead. But a little note goes a long way, definitely.
Yeah, I love hearing from the family doctors or the other doctors that are sending patients to me. And we sometimes, go back and forth with our faxes in our high-tech medical world where we still send faxes. Because sometimes patients change medication and I need to look for something different on their exam, whereas they might see like everything's the same, no new medications. But when I get a note from another physician saying, "Actually, they're on this medication, can you see if there's any ocular side effects?" It also helps me narrow down my exam, and maybe I would spend a little bit more time looking at something that, if everything was always normal, I might not spend as long looking if I didn't know I needed to. So I think the bottom line is communication between specialists is super important. And that's part of the reason why we want to do this podcast jointly today. We talk to each other a lot about this stuff, and we think, well, I don't want to speak for you, but I think that communication between specialists is important, and this is a good first step.
I definitely agree, Megan, and we will continue to have our conversations on a very candid basis, and hopefully this information has been useful for the listeners in terms of feeling more comfortable asking questions about thyroid, diabetes, headaches, and even other conditions with their family doctor as well as their ophthalmologist.
Yes, and on that note, thank you, Dr. Caitlin Reimer, for your time and patience.
Well, it's my pleasure, and thanks, Dr. Debra-Meghan Sanft as well.
All right, have a great afternoon.
And that concludes today's episode of the Broad Eye Podcast. If you enjoyed this episode, please be sure to subscribe on your favorite podcast platform. Of course, ratings and reviews are always welcome. And you can certainly share this episode with any of your colleagues or friends who might enjoy it. Thanks for listening.